Good afternoon,
J'aurais
everybody.
plus rien à faire, tu vois.
Can we save aorta from the knife today? Not 100%, not in every case, but yes, almost. The management of the vascular disease has undergone a major revolution. About a decade ago, open vascular surgery was the norm. The catheter-based technology has developed tremendously in the last few years. Endovascular therapy, therefore, is now the first option in most clinical situations. Open vascular surgery traditionally offered the gold standard with regard to durability and efficacy. However, it was associated with the typical morbidity and mortality of all open surgical procedures. The drawback of the open surgery, complications of general anesthesia, physiological changes of clamping and unclamping major vessels, significant intraoperative blood loss and fluid shift, impact of various types of skin, abdominal and thoracic incisions. With the goal of decreasing the morbidity of vascular interventions, the shift towards endovascular procedure is well justified. Surgical revascularization has been the traditional treatment for a variety of occlusive lesions of the aorta. Percutaneous treatment has replaced open surgical procedures as the first line of treatment for many of these lesions. Advantage of endovascular therapy, avoidance of general anesthesia, no incision, wound-related complications, reduced cardiovascular stress, earlier recovery and ambulation, and more easily performed re-intervention when if required. This was the case which had the coronary artery disease, triple vessel disease and the total aortic occlusion. The cardiac surgeon told me that we can do this case simultaneously. I will open the chest and you can do the laparotomy and you can put the aortobifemoral bypass. But finally we decided that first you do the CABG and later on I will do the aortobifemoral. This patient was operated on Wednesday, and after seeing his condition on Thursday, we decided to do the endovascular procedure, and we will not open this case. This was a total aortic occlusion infrarenal, and in this patient, we could pass our wire from the right femoral artery quite easily, but from the left femoral artery, it took quite a long time to pass, and ultimately we could negotiate after tromo and many hard wires, and we could negotiate this total aortic occlusion. And finally, we had put the 4 stents, 4 long stents, 2 bilateral. And this was the final picture. And 5th day, the patient was at home after the CABG and after the aortic revascularization without opening any abdomen with good distal pulses. This was the another case where it was again a total aortic occlusion infrarenal, and at one time it was almost we had to give up this case and decided to open, but finally we could pass our wire from both sides. In this case we had to face the difficulty passing the wire from the right side, and finally we could pass, and we had to put the 3 stents, 1 on one side, right side, and 2 on the left side. And so this was the, no sir, it was not the recent occlusion. That's why we had to face a lot of difficulty from the right side. And this was the remodeling of the stent. So this was the final picture. When to go for the open surgeries? The limitations of the endovascular therapy are related to specific anatomic considerations and questions of durability. When an endovascular intervention is not anatomically possible, open vascular surgery can be used in a hybrid fashion to modify the anatomy to make endovascular interventions possible. However, despite advances in the endovascular technology and increase in the number of endovascular interventions, open vascular reconstruction will still continue to play a significant role in the management of patients with aortic disease for the foreseeable future. Now, if we have to go for the aorto bifemoral bypass at our center in Gangaram Hospital, we don't open the abdomen and we do it robotic surgery. Thank you very much.
Thank you. We have a question from Professor Buckley.
You certainly have demonstrated that you can do this endovascularly. You can recanalize an aorta. But I think if you look at the data, at least that's out there so far, the 5-year patency for an aorta bifemoral graft should be around 85%. And for this recanalization is reported to be around 60%, 65%. So if you're doing this in an older person with a short life expectancy, probably not a bad thing to do. But in a younger person, I think I would still opt for open aortic surgery because I think the outcomes have been proven to be good. Now, maybe with newer devices, drug-eluting balloons, and it may be in stents or bioabsorbable stents, it may well be that recommendation would change. But I still think that the patency from an aortofemoral reconstruction is so good and so durable that for younger people, it's even though it's a more morbid procedure, I think it's worth it.
Thank you.
Michel, comment?
Yes,
Short.
I enjoy your talk because I think that all aortic, aortoiliac occlusion like that should be at first treated endovascularly. But I agree with Professor Buckley. The patency rate is not so good. But the indication for surgery maybe is failure and maybe restenosis if you can't redilate and do something else. But I think at first we have to do like that. That's my opinion. I'm not a surgeon.
So let's go to the, thank you very much. Let's